Yes, good evening all, and welcome to the last revision of pharmacology. And we are doing the part 3 revision here. So before I move on, just tell me the audio video is fine. Okay, so just confirm the audio is it's fine. So let me start, and at the end of this video, the annotated PDF will be provided. This is the Telegram group where you can find it. This is the Instagram for following up for any updates. So the last thing what we are going to do, we are left with 3 topics here. One is the CNS pharma, blood pharma, and RS pharma. So these are the 3 things which we are going to discuss. Yes, Himalayan, good evening. Just put a message, the audio will proceed. So let me start with the blood pharma now. In blood pharma, the first question will be a patient with breathlessness, chest pain, and irregular heartbeat. So irregular heartbeat points towards atrial fibrillation. She is a known case of mitral stenosis. So she has mitral stenosis as well as atrial fibrillation. Why? Please understand, if there is atrial fibrillation, the blood will become stasis, and stasis will lead to clot, and the clot may go to brain and stroke. So luckily there is no thrombi, but I need to stop the clot formation. What is the best way to prevent thrombosis in this patient? Himalayan, yes, it will help for FMG also. Please do listen to that. Now, mitral stenosis with atrial fibrillation, the anticoagulant of choice will be warfarin. So warfarin is a time-tested drug from so many years, which is more efficacious in this. So the answer will be A, oral warfarin. What about these 2 drugs, dabigatran, apixaban? These are called as DOACs, or these are called as NOACs. DOAC stands for directly acting oral anticoagulants. NOACs means novel oral anticoagulants. So these are used in non-valvular heart disease. Non-valvular heart disease with atrial fibrillation. Then I can give dabigatran or apixaban. But this is a valvular heart disease with atrial fibrillation. The preferred will be warfarin. So read the question carefully. What is the purpose of this MCQ? Is to understand the also called as antithrombotics. So let us jump into that. So made here is I have given the drugs, mechanism of action, any routine lab monitoring required, and any antidote they have. So the first drug what I am taking is rivaroxaban. So any drug ending with XA-ban, it bans the 10A. So they are direct 10A inhibitors. Now lab monitoring, no. Do they have an antidote? Yes. The antidote name also has XA net alpha. The name is hexanet alpha, but it has ande in front of it. It is andexanet alpha. Moving on to dabigatran. Dabigatran is a direct thrombin inhibitor. It's a direct inhibitor. So does it require routine monitoring? No. What is the antidote? The antidote, which daru? I daru cizumab. So it's a monoclonal antibody for dabigatran. So dabi matlab daru. Warfarin, the mechanism is it inhibits vitamin K. It's a vitamin K antagonist. So if you want that particular enzyme, it inhibits vitamin K epoxy reductase. Tell me, warfarin is a competitive or non-competitive inhibitor of the enzyme? Please tell me. Does it require a monitoring? Yes. The INR monitoring should be done. The antidote is vitamin K. So the question is it competitive or non-competitive inhibitor? Warfarin inhibits the enzyme competitively. That's why you can overcome that by giving vitamin K. Unfractioned heparin, what is the mechanism? It binds to antithrombin 3 and inhibits the factor 10A and factor 2A equally. Does it require a monitoring? Yes, it requires APTT as well as PT. The antidote name is protamine. The name is protamine sulfate. Anything ending with parin, they are low molecular weight heparins, noxparin, nardaparin. They also act through antithrombin 3, but here the mechanism is they inhibit 10A more than 2A. Do they require routine lab monitoring? No. If you want to monitor, you want to monitor. So what is the antidote? Same protamine sulfate. Fondaparinux, you see the name parin, it is also similar to heparin. It ends with ux. That means it also acts on antithrombin 3, but inhibits only X, that is 10A. Does it have an antidote? No. Does it have lab monitoring? No. Then the drugs argatroban and lepirudin, anything ending with rudin, these are direct thrombin inhibitors. Do they require lab monitoring? Yes, APTT as well as PT they require, and they don't have antidote. So in this table, you can understand the mechanism of action, what requires lab monitoring and what is the antidote, everything you can know from this. Right? That is the anticoagulants. But you can observe the first three are all oral drugs. But in that first two drugs are new drugs. They are called Novax. Warfarin, similar drugs are coumarin, dicumarol. I hope you got this. Now let us move on to the next question. 36-week pregnant female with prosthetic heart valve. Now please understand, if there is a prosthetic heart valve, anytime there can be formation of clot, and the clot may move, it can embolize and can cause stroke. So what is the next step? Try to answer this. What is the best next step? Try to answer this. Yes. Now, how to do this anticoagulation, particularly in heart valves in pregnant women? In pregnant women, we need to understand the risk of teratogenicity. From 0 to 12 weeks, first trimester, we can give low molecular weight heparin, which is an injection. We can't give warfarin because of the risk of teratogenicity. Some books give low dose can be used, but it depends on the risk. Now from 12 to 36 weeks, up to the end of 36 week, we can go with oral warfarin. Now you may ask a question, why can't we continue low molecular weight heparin only throughout the pregnancy? Number one, it's an injection, and it's very difficult to give injection for 9 months. Second, it will cause osteoporosis and long-term usage. Now, at the end of 36 weeks, that is at the starting of 37th week, we again shift the patient to low molecular weight heparin. The reason is warfarin is long-acting with a half-life of 40 hours. So if I don't stop warfarin, she may deliver anytime, and the bleeding risk is very, very high, postpartum hemorrhage. So it is ideal that at the end of 36 week, change to injection, because low molecular weight heparin are showing 8 to 12 hours, and their action will be gone. So at the end of 36 week, what is the best thing I can do is change to low molecular weight heparin. So that is what we can do in this case. Okay, hope you got this. This is a OBG question, pharma question. It's not a new question. It has been already tested. This has been already tested. So just let me check. Whole pharmacology lecture I will let you know. Okay. Okay. Then moving on to match the following. So match the mechanism of action. First we'll take up low dose aspirin. Low dose is between 40 to 325 milligram. And during MI we use this 160 to 325 milligram, and that is low dose aspirin. Low dose aspirin inhibits the COX irreversibly and decreases thromboxane. So the mechanism that matches is this. Inhibits COX irreversibly and reduces thromboxane synthesis. Second group of drugs, they end with grel. Clopidogrel, prasugrel. These drugs ending with grel, they block P2Y12. Now please understand they block the P2Y12 irreversibly. So grels inhibit irreversibly, and grels are prodrugs. That means they require activation, they take time. So then we came with the third concept, grel. You know grel, you add grelar, cangrelor, ticagrelor. So what do? They are reversible P2Y12 antagonist. So this confusion has to be avoided in the exam. Grel are irreversible, grelars are reversible P2Y12 antagonist. Number 4, abiximab and eptifibatide tirofiban. These are GP2B3A antagonist. Now parenteral drugs, and they are antiplatelet drugs. They are used in emergencies like acute coronary syndrome, and you are doing procedure called pulmonary intervention. So all these 4 what we have listed upon, they are all antiplatelet drugs. So they are used for prophylaxis of MI, prophylaxis of stroke. But for stroke prophylaxis, 3 drugs are used. Number 1, aspirin, clopidogrel, and dipyridamole. Stroke prophylaxis, 3 antiplatelet drug approved are aspirin, clopidogrel, dipyridamole. Sir, why can't we give others? Now, others, the main risk is hemorrhage in the brain. The risk is less with them, that's why these are used. Now, dipyridamole, can I give it in MI prophylaxis? No, because dipyridamole causes coronary stale phenomenon, which will worsen the angina. Number 5, we have enzymes, streptokinase, urokinase, alteplase, retiplase, tenecteplase. These are lytic drugs, so they lyse the clot. I think I will give the number 5 for this. They lyse the clot. Recently, one NEET PG, they had asked how they lyse the clot, because they increase the conversion of plasminogen to plasmin. So plasmin is the one, this is stimulated by fibrinolytics, plasminogen to plasmin. Then we have tranexamic acid and ECA. ECA stands for epsilon amino caproic acid. These are anti-fibrinolytic. So what do? They inhibit this conversion of plasminogen to plasmin. This was in the NEET PG last year, 2024. So if you make plasminogen to plasmin, plasmin will cut the clot. They are called fibrinolytics. If you block that step, they are called anti-fibrinolytics. So this table will give you the information which are antiplatelet, which are fibrinolytic, which are anti-fibrinolytic. This is fibrinolytic drugs. This is anti-fibrinolytic drugs. Now coming to other aspect, There is a common heparin that is called heparin-induced thrombocytopenia. The main problem occurs in that is not thrombocytopenia, it is mainly the question. So what is the drug I can give to prevent the clot formation? The drug name is argatroban. Argatroban can be used. Or you can give fondaparinux. This will prevent the clot formation, but never give heparin, low molecular weight heparin, because they themselves will do that. Now coming to the case 2, patient came with warfarin induced bleeding. What is the next step? I have giving warfarin to a patient. Now he is coming with bleeding. You may tell, sir, I will give vitamin K. But vitamin K takes time to work. He is already bleeding. So what does vitamin K reduce? It reduces 10 factors. So I should give them immediately. How? That is called 4-factor prothrombin complex. 4-factor prothrombin complex I will give. If that is not there, I will go for fresh frozen plasma. Sir, when should I write the answer as vitamin K? If they had asked you the antidote, then only answer should be vitamin K. Yes. So please read the question carefully. If they have given warfarin is given, and what is the antidote? Vitamin K. But already patient is bleeding. I have to stop the bleeding. That means I have to give the factors. A pregnant woman has dyslipidemia or familial hyperlipidemia. Which anti-dyslipidemia drugs are safe? The drugs are bile acid binding resins are safer in pregnant women. Can you tell me a name, sir? Cholesevelam, cholestiramine, cholestipol. So they start with col. They are safer. Why? Because they are not at all absorbed. If they are not absorbed, where will they go to placenta? Where will they go to the fetus and affect it? Yes, you are right. Learn and teach. Yes. Yes, Mohammed, you are right. Cholesevelam. Now, I have given some pointers for dyslipidemia drugs. Which dyslipidemia drugs are PPR alpha agonist? They cause myopathy, gallstone, used in dyslipidemia. These are fibrates. Take a guess. Fibrates. The names are fenofibrate, clofibrate, gemfibrocil. So recently they had asked a question, what will increase gallstone? That is fibrates. Yes, HMG-CoA reductase inhibitor, myopathy, diabetes risk, impaired liver enzymes, they are nothing but statins. Particularly two statins you have to remember, rosuvastatin and atorvastatin. Now rosuvastatin between 20 to 40 milligram and atorva 40 to 80 milligram. These are called as high intensity statins. They are called high intensity statins. Now where should I use high intensity statins? When I want to bring down cholesterol, particularly during MI. So there I use high intensity statin because these are the two drugs which can bring down the LDL by 45 to 55%. And that's why when there is an MI, we give dual antiplatelet therapy with statin. Yes. And the longest acting, yes, you are right, rosuvastatin is longer acting. Coming to high intensity statins are, I told you, they are the same drugs, rosuva and atorvastatin. Recently, this is a trending drugs, PCSK9 inhibitors. They are monoclonal antibodies like alirocumab and a drug called evolocumab. These are PCSK9 inhibitors. They are approved for familial hyperlipidemia conditions. Recently, they had asked a question about a drug which inhibits ATP citrate lyase. I'm waiting for your answers. Tell me that. Now, what drugs will cause maximum LDL reduction, triglyceride reduction, HDL increase? Maximum LDL is reduced by statins. Triglyceride maximum reduced by fibrates. Should you use fibrates? Fibrate should be used when the triglyceride levels are very high, more than 500. Right? Otherwise, statins will do. Maximum by niacin, the B3 vitamin. But what is the drawback of B3? It causes flushing, pruritus, increases uric acid, increases the risk of diabetes, myopathy risk. So that is why niacin sometimes is combined with aspirin to prevent pruritus and flushing. A very beautiful drug. So what is the drug name which inhibits ATP citrate lyase? The name is called bempedoic acid. This was an INI-CT question recently. This is a competitive inhibitor of this enzyme, competitive, but in the exam they had given it's a non-competitive. Where are we using this? We use it in a dyslipidemia patient who is already on maximum tolerated dose of statin. Or you can give this with ezetimibe drug also. Yes. This is about drugs for dyslipidemia. Please concentrate. PCSK9 inhibitors are frequently tested, and recently they have tested bempedoic acid. Bempedoic acid is used for familial hypercholesterolemia as well as to prevent atherosclerotic cardiovascular diseases, that is ischemic heart disease. Now coming to poison and overdose and the antidotes. So fibrolytic overdose. Suppose I give streptokinase overdose, patient will be bleeding. What is the antidote? The antidote is either epsilon aminocaproic acid or tranexamic acid. This is frequently tested. Second, iron overdose. Acute iron toxicity, we use a drug called deferoxamine or desferoxamine. Both are same. But if it is chronic iron poisoning, then we give oral drug. Oral drug, remember they start with defer. They defer, fer means iron, they remove the iron, defer. So they are deferricerox and deferiprone. But in the exam you may confuse it. Remember, if they start with defer and amine, they are given IV or IM. Obviously IV or IM are for emergency, that is acute iron poisoning. Acute iron poisoning. So if you remember that anything they give with defer, they are for chronic iron poisoning. Where you see chronic iron poisoning, thalassemia patients where we transfuse the blood repeatedly, the iron overload will happen. And where do you see acute iron poisoning? Usually kids. Parents would have kept the iron capsules, they don't know. They will swallow that and come to the hospitals. So that's why the questions are being tested here. So let us do other things. Yesterday also I told you paracetamol, it is N-acetylcysteine. Magnesium sulfate toxicity, the antidote name is, yes, any guesses? Magnesium sulfate, the antidote name is calcium gluconate. It is the calcium gluconate. Number 3, isoniazid. Yes, isoniazid overdose. We use pyridoxine. Isoniazid in also we use B6. Methotrexate we use leucovorin, folinic acid, citrovorum factor, all are same. Leucovorin, folinic acid, citrovorum. For methotrexate overdose, recently there is an enzyme approved. Any idea what is the name of the enzyme? It is called sulfonylurea. When we start sulfonylurea, patient will have hypoglycemia. How do you overcome that? The drug is octreotide. So please understand, every exam the antidotes are a must. Don't lose 1 mark. You will 100% get an antidote question or poisoning treatment. So let us go with 50-50. We did that. Post MI patient with severe gastritis. So post MI patients, I don't want one more MI episode. I give them antiplatelet drugs. I give them statins. So I have two options, aspirin and clopidogrel. Patient is having severe gastritis. Aspirin cannot. What I can give is clopidogrel. Choose one. Post MI patient, he is a poor metabolizer of cytochrome 2C19. So in that patient, will you prefer aspirin or clopidogrel? Why? So please understand the concept. Clopidogrel is a prodrug. You know, prodrug means it requires activation. So this will become active. To make it active, we require enzyme cytochrome 2C19. These are enzymes. Enzymes are protein. Proteins are genes. Suppose somebody has problem in these genes. Will the clopidogrel work? No, they are called poor metabolizers. So that is why in this patient I will prefer aspirin. Yes, one more interaction we have to understand here is a PPI called omeprazole. So can we give omeprazole with clopidogrel? Never, because omeprazole inhibits cytochrome 2C19 and it will not give any protection. Coming to the next problem, valvular heart disease with atrial fibrillation. We took this case. Will you prefer warfarin or Novax? I'll prefer warfarin if there is valvular heart disease. Same non-valvular heart disease with atrial fibrillation, I will prefer Novax, that is dabigatran or anything ending with hexaban. So this is how you need to choose in your exams. This is how the questions would be asked. Okay, yeah. Let us discuss some drug interactions, very, very important. Can we use aspirin and warfarin together? Yes, you can use it, but you have to monitor for bleeding risk because aspirin is an antiplatelet drug, warfarin is an anticoagulant, so bleeding risk is there, but you can give them, but careful. Lithium plus thiazide, no, because lithium plus thiazide, lithium causes hyponatremia, and because of that the kidney starts absorbing more sodium, more lithium, so this will lead to lithium toxicity. So don't give them together. Tetracycline and antacid or milk. Remember, tetracycline gets attracted to any bivalent ions like iron, Fe2+, calcium. So calcium is present in milk. Antacids contain magnesium, calcium. So they combine with tetracycline and tetracycline will not get absorbed. So don't give it. There is decrease in tetracycline absorption. Can we give iron with vitamin C? Obviously, because you know Fe3 ferric should become ferrous and that is going to get absorbed. And that is done in acidic environment and that is provided by vitamin C. Yes. Iron with PPI? No, because PPI will reduce the acidic content and iron absorption will happen. That's why if you give PPI for very long periods, patient will have iron deficiency anemia. Can we give OCPs and rifampicin together? No, because rifampicin is an enzyme inducer. OCPs metabolism become faster, there is contraceptive failure. Omeprazole plus clopidogrel, just now I explained that, not given together. Sucralfate plus antacids, not given because sucralfate works at pH less than 4 and antacids will elevate the pH more than 4. So combination should not be given. I hope you understood the importance of these combinations. Okay. Now, once we are done with that, let us move on to the next topic, the CNS pharma, central nervous system. In CNS, let us start with an MCQ. 25-year-old female, increased heart rate, sweating, and excessive worry from last 2 hours. Acute anxiety was diagnosed and was started on a drug which can act rapidly. Which was used. So it's a case of acute anxiety. What drug will you use? For acute anxiety, the drug of choice are benzodiazepines, and the benzodiazepine here is lorazepam. Lorazepam is a drug of choice for acute anxiety. It is a drug of choice for status epilepticus. It's a drug of choice delirium tremens, which is seen after stoppage of alcohol more than 48 to 72 hours. Buspirone, yesterday also I told you it's a 5-HT1A partial agonist. Buspirone is approved for chronic anxiety or generalized anxiety disorder. Vilazodone and a new drug vortioxetine. These two are novel antidepressant. Novel means new. They are used for major depressive disorder. Escitalopram is a SSRI. SSRI are the drug of choice for chronic anxiety or general anxiety disorder. But for acute, you have to give benzodiazepines. That is the answer. C. Now, 65-year-old patient present to the hospital complaints of tremors, bradykinase rigidity. He was started on MAO-B inhibitor, which is a MAO-B inhibitor. So let us analyze each option. Capone. Anything ending with capone is a COMT inhibitor. Anything ending with gelin, selegelin, rasagelin, these are MAO-B inhibitors. Recently, we have a drug by the name safenamide, which is also MAO-B inhibitor. We know levodopa is given with carbidopa. Then we have pramipexole, ropinirole, rotigotine. These are also used in Parkinson's. These are non-ergot D2 agonist. So we have COMT inhibitor, MAO-B inhibitor, levodopa. These are the drugs for Parkinson's disease. Are there any other drugs for Parkinson's disease? We have a drug called estradiol. Estradiol sounds like theophylline, but it is used here for decreasing off episodes in Parkinson's disease. It blocks adenosine receptor. Apart from that, we use drugs such as amantadine, rimantadine. Then we use anticholinergics like benzaxole, benztropine, bipyridine, promethazine for Parkinson's disease. Then the ergot D2 agonists we use in Parkinson's disease, they are bromocriptine and cabergoline. Okay, so I was telling you ergot D2 agonist, bromocriptine and cabergoline. These are the drugs used in Parkinson's disease. Now again, in any exam, they will ask you the addiction and how to de-addict them. So first we have taken up the alcohol. Which of the following is aversion therapy in chronic alcoholics? Aversion is done by disulfiram. Disulfiram inhibits the enzyme aldehyde dehydrogenase. So what happens if we inhibit this? The acetaldehyde levels goes up. Patient will develop nausea, vomiting, headache, chest tightness, respiratory difficulties. So whenever he drinks alcohol with disulfiram, he won't have the euphoria. So it will lead to aversion therapy. But another problem in alcoholics, they have craving. They will try to leave the alcohol for 5 months, 6 months. Then there is craving. The drug which is used to decrease craving in alcohols are naltrexone. There is a mnemonic nota. Naltrexone, ondansetron, topiramate, acamprosate. These nota drugs are known to decrease cravings in alcoholics. So when I talk about alcohol, they will be testing repeatedly. What is the drug of choice for delirium tremens? Patient was chronic alcohol, suddenly stopped, lorazepam or chlordiazepoxide. Now again they will ask you, chronic alcoholic comes with hypoglycemia, how do you manage? You have to give B1 and then glucose. Again there is a case of Wernicke's encephalopathy, Korsakoff psychosis. Which vitamin will you give? B1, thiamine. Questions from alcohol. Aversion means you don't feel like drinking, you feel like bad about that. Aversion. Looking at that, you don't feel like drinking. Aversion. Coming to varenicline, bupropion. These are the drugs which are used to stop smoking, smoking cessation. For smoking, we have 3 treatment: varenicline and nicotine replacement therapy. Varenicline is the most effective among this, and it's a nicotinic partial agonist. What is bupropion? Bupropion is a NDRI, noradrenaline dopamine reuptake inhibitor. So the most effective therapy will be varenicline. So I am discussing everything here. Okay, sir. Alcohol we are done. Smoking we are done. Then come to the next question. What is the drug used for maintenance therapy of opioid? Now suppose a person is opioid addict. He is an opioid addict. There are 3 scenarios we come across. First scenario is an opioid addict. He is taking opioid every day and suddenly stops. So what happens? He will go for withdrawal symptoms. The withdrawal symptoms is sympathetic surge, anxiety, tachycardia, everything. That time I have to suppress the sympathetic. I can give clonidine or I can give lofexidine. That, and also I can calm down the patient by giving. Second, patient comes to you and tells, sir, I am an opioid addict, I want to quit. Then you have to replace that. That is called maintenance therapy. For that you can either use a drug called buprenorphine or so he may go for relapse again. Then how to prevent relapse? We use a drug by the name naltrexone. So please read the question carefully and try to answer. So here, maintenance therapy, what I can give is buprenorphine, or if there is methadone in the option, you can give it. Lofexidine and clonidine, they are used to treat withdrawal symptoms. Disulfiram is for alcohol. Now coming to seizures, epilepsy, most of the questions will be based on the drug of choices. For GTCS, absence, juvenile and myoclonic, the drug of choice is valproate. If that is not there in the option, nowadays we have lamotrigine that can be used. Now most students ask me this question, sir, absence seizure, what is the drug of choice? See, absence seizure, the drug of choice is valproate. But the problem is in children, can I use valproate? Because valproate is hepatotoxic. It's a very toxic drug. So in child, if they are given absence seizure, and there is an option called ethosuximide, choose it. Give ethosuximide. Otherwise, if they are not given any child or something like that, febrile, absence seizure, go for that. Trigeminal neuralgia, the drug of choice is carbamazepine. Carbamazepine. See, less than 2 years, more than 2 years. Which book they have given? Somebody wrote that 5 years ago, and they are following the same thing. So any childhood absence seizure, ethosuximide is fine. Febrile seizures, nowadays we can give intranasal midazolam, which is easy to administer. If that is not there, rectal you can give diazepam. Rectal diazepam. Again, there is infantile spasm, West syndrome, hips arrhythmia, salami spell. So for that, the drug of choice is ACTH. But same problem with tuberous sclerosis. The drug what we use is vigabatrin. Vigabatrin mechanism easy to remember. It's a GABA transaminase inhibitor. But the adverse effect of vigabatrin is vision impairment. That is why even though it is a very effective drug for infantile spasm, I don't want to give to infants, because infant cannot tell vision impairment. They cannot talk only, then why will they tell? Coming to magnesium sulfate, eclampsia, the drug of choice is magnesium sulfate. Status epilepticus, we give lorazepam or diazepam. Still not responding, then we go for fosphenytoin, levetiracetam, or valproate. Still not responding, then go for phenobarbital. The last resort is general anesthesia. General anesthesia, you can give it propofol or midazolam. So this is the flow of treatment for status epilepticus. Yes, most of you are answering very well. Muhammad Hassan, Learn and Teach, Chiku, Rama, you are back, very good. Yes. So this is about the drug of choices. Now let me take true or false here. Phenytoin and carbamazepine are not used in myoclonic and absence seizure. What do you think, true or false? It's a true statement, because if I use them in this seizure, the seizure will increase. Anti-epileptics used in neuropathic pain, they are gabapentin, pregabalin. Now, which neuropathic pain they are used? They are used for post-herpetic neuralgia, diabetic neuropathy. Now, they are also drug of choice for restless leg set, carbamazepine. The next thing is, do anti-epileptic require therapeutic drug monitoring? Yes, true. We have to monitor their drug levels. Which anti-epileptics are also used in bipolar disorder? Valproate, carbamazepine, lamotrigine. So these three are used for bipolar disorder also. So that is about anti-epileptic drugs. I think there is some problem. Okay, so please wait. There was some internet issue. So thrombocytopenia, PCOD, curling of hair, alopecia, valproate. Remember hepatotoxicity, HAT, hepatotoxicity, hyponatremia, thrombocytopenia, allergy, and ataxia. These are seen with carbamazepine. So what should be remembered? I have made them in red. So whenever you see gum hemiplegia, hirsutism, fetal Hydantoin syndrome, megaloblastic anemia, we go towards phenytoin. Right? So recently in INICT they have tested neural tube defect. So these are the anti-epileptic drugs you can guess. And if a vision impairment occurs, you can guess it is due to mega battery. I think now it is fine. Now the next question commonly tested in the exam is the extrapyramidal symptom by haloperidol. Haloperidol is a typical antipsychotic, means it blocks dopamine receptor. What will happen when you block dopamine? The first thing that happens is acute tachypolis or the uprolling of eyeball oculogoric crisis. The treatment is anticholinergic benzhexol. Another name for benzhexol is trihexyphenidyl. If that is not there, you can give promethazine. Suppose you give haloperidol to elderly people, they develop Parkinson-like symptom that is called drug-induced Parkinsonism, tremors, rigidity, bradykinesia. The treatment for that is also same, benzhexol or promethazine. Number 3, akathisia. Akathisia means patient cannot sit at one place, he keeps on moving. So the drug what we use is a beta blocker by the name propranolol, or you can use benztropine or benzodiazepine. So these are the three options what we have, but the first choice will be propranolol. The first choice will be propranolol. Now suppose I will ask you a question. Suppose a patient is having akathisia and patient is having asthma. Now you have to tell me whether will you choose propranolol or will you choose benztropine. I put this like this. Patient has akathisia and asthma. Will you prefer propranolol or benztropine? Please answer. Number 4, neuroleptic malignant syndrome. Whether rigidity, temperature is very high, myoglobinemia. The drug of choice will be dantrolene sodium. It's a muscle relaxant which inhibits rhinodin receptor 1. And I told you, it is also drug of choice for malignant hyperthermia caused by succinylcholine, halothane, desflurane, like that. So I was asking you a question, akathisia and asthma, then I cannot use propranolol because it's a non-selective beta blocker, blocks beta 2 and worsens asthma. So in those patients, I will choose benztropine. The last complication that will happen if haloperidol is given for long is tardive dyskinesia, abnormal movements. For that, we have VMAT2 inhibitors and they end with benazins. They end with benazin, valbenazine, tetrabenazine, like that. They end with benazin, valbenazine, tetrabenazine, like that. So, this is a psychiatric question, pharma question repeatedly asked. We have made that in sequential manner. So first day, 2D, 3 days, you see dystonia, and after so many years, you see tardive dyskinesia. Suppose I give haloperidol today, tomorrow the dyskinesia will not happen. Tomorrow will happen dystonia or oculogyric crisis. That too in younger people. Elder people, you suspect Parkinson's symptoms. Clear? So this is seen with typical antipsychotics. Risperidone is an atypical antipsychotic. It is FDA approved for schizophrenia, yes. Mania, yes. Bipolar disorder. Hyperactivity in autistic disorder, true. Because mania and bipolar, they are also like psychotic disorders. Atypical antipsychotic causing extrapyramidal symptom at high dose. Typical antipsychotics cause less extrapyramidal symptom, less hyperprolactinemia. They don't block alpha muscarinic histamine. But what is that which can do that at higher dose? That is risperidone. Aripiprazole is an atypical antipsychotic property, true. Don't confuse piprazole with pantoprazoles. These are atypical antipsychotics. Okay. Now, can you guess the drug by looking into the image? I'll give some time for you people. Guess it. What are these drugs? Patient is eating cheese, drinking wine, beer, and you can observe the BP has gone up 203 by 114. So what is this? What drug the patient is on? Guess. So in between, if you are liking this, just put like button, push the like button, subscribe to the channel. Share to your friends also. We have 3 parts in this. Share to them if it is useful for them also. Yes, you are right. So patient is on depression and he is on MAOA inhibitor. And eating cheese, wine and all, they increase tyramine in the blood. Because tyramine won't get metabolized. And tyramine is an indirect acting sympathetic which increases norelin and that increases blood pressure. So this is cheese reaction. Let me see how many of you got that. So the BP is high. How do you bring down BP? Give antihypertensive. So the antihypertensive which can be given is phentolamine, which is an alpha blocker, can be given. Okay, so I'm not able to see your live charts. Yes, so the reaction is cheese reaction. Okay guys, so just tell me any problem whether the streaming is going right, because I'm not getting any input. Yes, Rutul Shah, Chiku, tell me the streaming is fine. Okay, so thanks for your messages. Then moving on to the next one, a drug is used for depression, acts by inhibiting both serotonin and oral reuptake, that is SNRI. So which of the following is an SNRI? SNRI is venlafaxine. So venlafaxine, milnacipran, duloxetine, these three are SNRI. Bupropion is the NDRI, an atypical antidepressant. Fluoxetine is an SSRI. You know fluoxetine, fluoxamine, sertraline, paroxetine, escitalopram, then dapaoxetine. All these come under SSRI. They all come under SSRI. So the SNRI drugs are venlafaxine, milnacipran, duloxetine. So the answer is this. Okay. Now moving on to the next one. A female developed pain and insect crawling like sensation at legs at night, which is relieved by shaking her legs. Which of the following is the drug of choice? Now what is this condition? Insect crawling like sensation relieved by shaking. It is restless leg syndrome. Nowadays the drug of choice are either gabapentin or pregabalin. The second choice are the non-ergot agonists like pramipexole, ropinirole, ruticotin. So here the answer is B. Answer is B. Next question, MCQ. A 30-year-old male is on drug therapy for psychiatric problem. He complains of increased urination and being thirsty. He starts getting acne and weight gain. What is the most common drug? What is the likely drug? Clonazepam is a benzodiazepine. Most of the patients will complain of drowsiness, sedation. Try that. Clozapine, it mainly produces wet pillow syndrome, that is hypersalivation, rarely agranulocytosis, myocarditis, and high dose seizures. Haloperidol we have discussed. Typical antipsychotics. Haloperidol also blocks alpha, leading to hypotension, histamine leading to sedation, leading to dry mouth, blurring of vision, constipation, urine retention, tachycardia. Can you tell me another psychiatric drug which will block all these three? They are TCS. TCS are tricyclic antidepressant, imipramine, desimipramine, amitriptyline, nortriptyline, doxepin. Now, what is the drug? Polyuria and thirst, acne. It is lithium. So here it is lithium-induced diabetes insipidus. That's why the drug of choice to manage this, I will give a clue. The drug starts with AM. Try to answer it. The drug name starts with AM. Amyloride. Now what is amyloride? It is an ENaC, epithelial sodium channel inhibitor. So if I inhibit epithelial sodium channel, lithium will not enter the collecting duct and it will not inhibit the action of ADH. If it doesn't inhibit ADH, then there is no polyuria. So this is the mechanism. Now we have given adverse effect. You have to guess the CNS drug. Guess the drug. Drug causing polyuria. We just now told Epstein's anomaly, CVS defect, given in pregnant women. If you give in pregnant women, tremors, remember, the drug which do that is lithium. So as soon as you see Epstein's anomaly, you should tell lithium. Now tremors, two types of tremors, lithium, fine tremors, coarse tremors. Now can you tell me, looking at tremors, can you tell whether there is lithium toxicity or not? Tell me. See, if the tremors are given fine tremors, the dose is fine, no problem. But if the tremors are coarse tremors, you have to suspect lithium toxicity. Lithium can cause hypothyroidism and hypercalcemia. But the question is, if patient is on lithium and develops hypothyroidism, then what will you do? Continue lithium, treat hypothyroidism with T3, with levothyroxine. Lithium can also cause acne and weight gain. It can also increase leukocyte count. Lithium is used in a special type of headache called hypnic headache. This is not being tested till now. It is used in hypnic headache. But lithium has one more specialty. Lithium has anti-suicidal property. Tell me one more drug which has anti-suicidal property. Yes, and one more drug. The name is clozapine. There are two well-established drugs having anti-suicidal property. One is lithium and one is clozapine. Which CNS drug causes livedo reticularis and ankle edema? A drug used in Parkinson's disease, the name is called amantadine. Which drugs in CNS can cause gangrene? They are nothing but ergotism. What drugs in CNS can cause metabolic syndrome? They are atypical antipsychotics. Can you tell me some atypical antipsychotics, sir? Your famous olanzapine. So olanzapine causes more weight gain compared to clozapine. So the risk of metabolic syndrome is more with olanzapine and clozapine. And the least effect is seen with new drug aripiprazole and ziprasidone. So they cause least metabolic problem, and also they cause least cognitive dysfunctions. I hope you got this adverse effect, the drug names and everything. Now coming to insomnia, anxiety, diarrhea, sexual dysfunction leading to anorgasm, delayed ejaculation, which CNS drug we use suspect? This is for you guys. Please guess it. Anticholinergic, antihistamine and alpha blockade, I told you, it is typical antipsychotics. And TCS. Priapism is trazodone. Yes, Ratulsha, you're right. SSRI, this is a favorite for NEET PG people. Adverse effect of SSRI. Insomnia, diarrhea, anxiety, sexual dysfunction. The last drug you can suspect, agonocytosis, sialuria. Sialuria means excess salivation leading to the pillow becoming wet, wet pillow syndrome. Myocarditis, seizures are seen with high dose. What drug is that? Clozapine. Yes, Hassan, you are right. You wrote fluoxetine. Yes, that's SSRI. That is also correct. Okay. Now coming to other points, dehydration, hyponatremia, fasting and diarrhea increases lithium toxicity. True or false? Try to guess. It's a true statement. In these cases, dehydration, hyponatremia, fasting, diarrhea, the sodium are less. When sodium is less in the body, what will the nephron do? It reabsorbs more sodium from PCT. Now sodium and lithium are treated same way in our body. So when sodium is reabsorbed more, lithium is also reabsorbed more. And you know lithium has narrow therapeutic index. You have to maintain between 0.5 milliequivalent to 1.5 milliequivalent. So a bit more lithium will lead to toxicity. And if the levels are more, you have to go for dialysis. But the normal levels is between 0.5 to 1.5 milliequivalent per liter. Therapeutic drug monitoring of lithium is done after 5 to 7 days. Why, sir? Suppose I start lithium for mania or bipolar disorder. Lithium has half-life of 1 day. Tell me, if it has half-life of 1 day, then how many half-lives are required to achieve steady state? Around 4 to 5. It means I can accurately measure lithium after 5 days. So we have taken 2 days extra, 5 to 7 days. After starting therapy, and blood drawn after 10 to 12 hours post-dose. Suppose patient has taken 9 lithium, so the levels will go up, and in the early morning the levels will come down. So we take the blood sample when the levels are, this is called trough levels. So post dose 10 to 12 hours, when the levels are low, that time I have to take the blood sample and check whether lithium is there or not. Sir, why can't I take after 9 p.m? After 9 p.m, anyhow I've taken the drug, obviously it will be high only. But I should be checking whether the levels are maintained of 10 to 12 hours. Then only the drug will work. So it's a true statement. Okay. So that is about CNS pharma. The last topic what I am going to cover is the respiratory pharma. Okay, so please put a message whether this session is becoming useful for you, you are able to revise the things. Okay, then we'll proceed further. Usually I would have finished it in one session, all these three, but some healthy reasons I couldn't do that. That's why I'm doing it in a phased manner. Now, moving on to the next question. A 56-year-old male had COPD, and doctor prescribed a SAMA. SAMA means short-acting muscarinic antagonist. So we have to find out which of the following is a short-acting muscarinic antagonist. So the answer is ipratropium bromide. It is a SAMA. We have a drug called tiotropium bromide. I told you, usually drugs with T, they are longer acting, so long acting muscarinic antagonist. Formoterol, now aminophylline, theophylline, they inhibit phosphodiesterase. They also inhibit adenosine. That is their mechanism. Magnesium sulfate inhibits calcium entry and cause bronchodilation. See, please remember all these options what you have written. They are all bronchodilators, and I have told you the mechanisms. All A, B, C, D, they are used for asthma. Ipratropium and tiotropium, they are mainly used for COPD compared to asthma. This is the point. So I hope you got the drugs. Now coming to adverse effect, all are salbutamol side effect except hypoglycemia, hypokalemia. Can you answer this? So the answer is hypoglycemia. Remember, salbutamol, it's a beta 2 agonist. So it causes 3T, 3H. What are the 3 T's? Tremor, tachycardia, tolerance. 3H, hyperglycemia, hypokalemia, hypotension. Yes, we confuse hyperglycemia, hypokalemia. How to avoid this? Remember, A, B, C, D, E, F, G comes first. H, I, J, K. So what is up? G. What is down? K. So hyperglycemia, hypotamol. So Rutul Shah, I hope you will not make this mistake in the exam. So don't try to delete your comedy, doesn't know everything. At least be proud that you people are answering proudly in this comment section. So make mistake here. And if you make mistake here, the brain will correct and that mistake won't be repeat in your exams. So don't worry. So the answer is A. It will not cause hypoglycemia, it will cause hyperglycemia. Now methylxanthines, I told you they mainly inhibit adenosine. They inhibit the enzyme phosphodiesterase. But what is the adverse effect? Adverse effect tea, what we drink. What happens if you drink excess of coffee? It will lead to CNS stimulation, seizures, more urine, headaches, nausea, vomiting, gastric discomfort. In the heart, it will lead to arrhythmias. So one of the exam they had asked, what is this due to? CNS, seizures and renal diuresis. This is due to inhibiting adenosine. What is this headache, nausea, vomiting, gastric discomfort? It's due to inhibiting 4. And what is due to arrhythmia? Arrhythmia is due to inhibition of adenosine and inhibition of phosphodiesterase 3. So you see this correlation. Let me give a correlation here. What is the drug of choice for arrhythmia? PSVT. The drug of choice is adenosine. Suppose I block that adenosine, what is the adverse effect I see? Arrhythmia. So adenosine is an antiarrhythmic. Suppose I block adenosine, you see arrhythmia. Montelukast. It's a leukotriene receptor antagonist. Any drug having chrome, nidochromyl chromoglycate, these are mast cell stabilizers. And these are given by inhalation route. How do we give them? Inhalation. Xyluton, it has Leu in the name. It inhibits LOX lipoxygenase. Omalizumab, it blocks Ig. It's Ig blocker. Reslizumab, benralizumab, mepolizumab, these are recent drugs. They block interleukin 5. Now, these last drugs are reserved for severe eosinophilic asthma. Now, please remember all these drugs are used for prophylaxis of asthma. The question asked in the exam is, are they used in acute attack of asthma when there is bronchoconstriction? No, they are only for prophylaxis. That is the question they keep on asking. And simple strategy when there is asthma, we start with short-acting beta-2 agonist whenever they get attacked. But if that attack is not controlled, we add inhaled steroid. Then we increase the dose of steroid. Then we add LABA. And the last resort for asthma control will be systemic steroid, that is prednisolone. That is the last resort. Most common adverse effect of inhaled or by using a spacer. The treatment for that is we use clotrimazole locally. It will come as a paint. If that is not working, we go for fluconazole oral. That can be used. What is the new phosphodiesterase 4 inhibitor used in COPD? The name is called loflumilast. New M3 antagonist used in COPD is revafenacin. Revafenacin. These are the new updated drugs for COPD. Phosphodiesterase 4 inhibitor is roflumilast. M3 antagonist is revafenacin. Have you heard of darifenacin, overactive bladder? Revafenacin is for COPD. Yes, very good, Hassan. Now, in any exam, you check PYQs, PYT, they will always give a patient with asthma and which drug you want to give. Now, these are the drugs which we never give in asthma patient. Morphine, we don't give because it causes bronchoconstriction. Cholinergic drugs, I gave an example, bethanocol, which is used in overactive bladder, cannot be given in asthma. Histamine, obviously, we don't give. Adenosine, I told you, PSVD with asthma, adenosine can't be given. Carboprost, recently asked. Patient was having PPH, asthma, which one you don't give carboprost? Timolol, because they are non-selective beta blockers, we don't give it. So please mug up these things. And I am telling you the application part. Now moving on to the choose the preferred drug. Suppose they give like this questions in an asthma patient. See, drug and bronchial asthma is a preferred question. Suppose a pregnant woman has hypertension. Will you choose labetalol? Will you choose nifedipine? I want your answers. Yes, we'll prefer nifedipine because labetalol is a non-selective beta blocker. Yes, this was the same question asked in FMG and most of them mark labetalol. Atrial fibrillation in asthma patient, will you prefer beta blocker verapamil? I'll go for CCB. I don't want to take risk with beta blocker. Suppose a patient has postpartum hemorrhage and asthma. Will you give oxytocin or carboprost? I will give oxytocin. Carboprost, I don't give. Glaucoma and asthma, will you give bitoxolol or timolol? I will give bitoxolol. Timolol is a non-selective beta blocker. I don't want to give. PSVT and asthma, will you give adenosine or verapamil? I'll give verapamil. Why not adenosine? Because adenosine is a bronchoconstrictor. So you check any years of paper, these type of questions have appeared a lot. Drug and bronchial asthma. I know you have studied from various sources, you have the notes, but combining all these things, what is being tested, and one point is more important. Now, this is what we have done in this revision session. So whatever you have done, it's just we are extracting and putting it in one table. So it is easy to revise. So that's it from my side for this NEET PG 2025. Because I have seen students across various, I have taught in various platforms. So that's why I had to get a revision for you all. And so most important thing for any exam is best of luck. So it is your effort you have done, 100% you have given. So along with that, God, suppose the questions are coming from the topics which you read and they are the one you are answering, your luck is good. So effort, luck and God, all these are very, very important. Let all this combine and you get a very good seat in the NEET PG. and don't forget to message me with your results. So thank you all. Take care, and we'll meet you soon. Any doubt, you can ask me in the Telegram. Thank you all.